Hi, it's Dr. Noel Williams, Optimal Health Associates, Oklahoma City, Oklahoma, December 12th, 2020. COVID update. So, COVID cases yesterday in Oklahoma was about 3,900. We had 30 deaths approximately. We've crested over 2,000 deaths. I think all of us now are starting to know people who've died of COVID, unfortunately. That's going to continue, and hopefully that will, while unfortunate, encourage people to wear their masks. The governor this week did place some further restrictions. I mean, some people really didn't think it was far enough. Some people thought it was horribly too far. It just illustrates the battle between the views of business and healthcare. And I'm not going to make a judgment on any of it since I've participated in. I mean, we've pushed as hard as we can and the governor's listened. But for every doctor and healthcare provider pushing for more restrictions, there's 100 people pushing for less restrictions, and that's because of economics, and we don't want people to starve to death and things like that. So it's a really complex issue. But I will say that we drove over to Fayetteville today to pick up a puppy, and I was amazed at how few people were wearing masks when we stopped at a gas station to and from, and that there's just so few people, at least I'm sorry, in the Tulsa area and in Arkansas wearing masks. I was a little frightened, actually. I mean, they don't have masks on. Now the people at the Love's Country store did, but the people going in, a lot of them didn't. So I was just flabbergasted by people just not paying attention, but what do you do? Because they're not the type of people you want to look at and go, hey, you need to wear a mask either. So anyway, so that's really my summary. Wear your mask, wash your hands, do what you have to do, but otherwise stay home, eat at dinner at home. We took takeout to support a restaurant when we got back. And I think that's all really good ideas. I mean, get takeout, but eat at home and start doing that stuff. So Kim has some questions. We're going to talk a little bit about ivermectin tonight and a few other things. So go ahead.
Okay, yeah, you had a lot of questions on the vaccine last time. Are there other RNA vaccines in the works besides just the COVID ones?
Currently, no, not really. There has been 3 phase 1 trials of messenger RNA vaccines, and there wasn't any issues with them, but as far as I know, there's not any big push right now on developing messenger RNA vaccines. The ones that were developed in their phase 1 trials, in the phase 1 trials, did not show any significant harm.
Can you take Plaquenil? Oh, this isn't a vaccine, sorry, but can you take Plaquenil and ivermectin at the same time? You can save that one for after if you want.
Yeah, we'll save that one.
Okay. How long will the vaccine stay in your system? You said it creates antibodies in your system as if you got COVID, and with the natural immunity, they're saying it's 3 to 6 months. Will it be the same with the vaccine?
So the question is, does the vaccine create antibodies that are the same as the virus? And since they're saying the viral, if you get the infection, they only last 3 to 6 months. So the first thing is, all of this is horrendous horse manure, okay? I'm sorry. The vaccine efficacy is solely based on hitting the antibody levels of someone who got sick. So if that's its sole measure of efficacy that Dr. Fauci thinks was so important, maybe getting the virus and having that level of antibodies from it really matters. And so I think the first thing is, no one knows how long that the antibodies are going to last from the virus, but it's not the antibodies, it's the B cells, the B lymphocytes that get programmed. They're going to be there. If you look at SARS, it sure looks like it gave cross protection to COVID. Coronavirus definitely does also for 30%. So it's really hard to imagine you're not going to have a longer term protection from your your B lymphocytes than 3 to 6 months. It just doesn't make any sense. And so when there's a big mutation in the virus, then it will probably matter, but there hasn't been. So until there is, I just don't think it's super important. That's my opinion. There'll be other people who disagree with me. I'm totally on board with you disagreeing with me, but you have no proof I'm wrong either. So let's go with the last 100 years of immunology, okay? Instead of the baloney that's always being said. If you look at some of the smartest immunologists in the world, they think there's longer term immunity than what anyone in the United States is saying, and most of the narratives in public health across the world. But they're scientists and they're not, and so no one listens to them because this isn't about science with COVID. Number two, the vaccine is going to give you antibodies, and the Pfizer vaccine data, the laboratory data definitely indicates the neutralizing antibodies inactivate active viral particles. How long they're going to last for is probably going to be for a while. We don't know yet. Pfizer doesn't know yet. Hopefully they'll last at least 3 to 6 months, maybe longer. But again, you're programming these B lymphocytes to respond. So I think that is a really important concept. But the other issue is we know that vaccines don't work as well as actually getting antibodies from the illness. So we just have to wait and see what the efficacy is of the vaccine. I think the Pfizer vaccine looks like it's going to be really good. The actual clinical outcome is going to be really good. And the Moderna vaccine shows the same or similar data. I don't think the Oxford AstraZeneca one does at all, but it's not approved yet, and it's a ways down the road, and I would avoid that one. Sorry for anyone who's an AstraZeneca person, but they went back on all the scientific principles they said they were going to follow on the vaccine, and they've combined trials, which they weren't supposed to do, and then did a meta-analysis, which they weren't supposed to do, just to try to prove some level of efficacy. So that one's the avoidable one. Did that answer that kind of, sort of?
I think so.
Sort of.
Let's see. How is the COVID vaccine different from the flu vaccine, since both COVID and the flu are RNA viruses?
Because when you're getting almost every other vaccine, you're getting some type of actual either inactivated viral particle or inactivated proteins from the virus. This is not that. This is the building block step before. So you take messenger RNA that turns cells on to make proteins, and those proteins are what erupt on the cell surfaces that you make antibodies to. So you're doing it in a totally different way. So instead of chopping off part of the virus and giving you a shot of it, that's the part that binds to you, so you'll make antibodies then to that, so you can then have those circulating around when you get the virus. Or if you've given someone a live, they say use the word attenuated virus, meaning that the active part of the virus isn't there anymore. It's just the shell of the virus per se. So once again, you'll develop immunity to it, you'll develop antibodies to the virus, so when it actually attacks you, you can fight it off. This is not that at all. This is giving you messenger RNA of COVID that code for the protein that's called the spike protein on the surface, or if we use our little model, it's the sequence of messenger RNA that makes this protein, which is what binds to your cells. So if you have antibodies to those spike proteins, they're all going to get knocked out before they can bind to your cells and infect you. So it's a building block that's going to turn your cells on into making the protein. That has never been done before in a large population-based group.
Okay. Will zinc interfere with the vaccine?
No natural things interfere with the vaccine.
Okay. During any of the vaccine trials, were any of the participants, did they have health issues or immunocompromised or any of that?
Well, some of the specifics we don't know. My guess is they were healthy volunteers, because it's the first, I think that's your first look group, is always you get healthy volunteers. You don't get subgroups. You don't do kids. You don't do pregnant women. You don't do outliers. You do healthy volunteers.
Okay. And then one person wanted to make sure, because tonight you said to you that the best way to get immunity is to get COVID. She feels like people may take that as an encouragement to go to parties and to do things. So.
No, I'm not saying get COVID. I'm just saying if you're if you compare getting COVID and the immunity from that to a vaccine, the COVID immunity is always going to be better. I mean, it's just the nature of it. I'm sorry. But we don't, the reason we want you to get the vaccine, which I've said, if you're in a high risk group and you get the ability to do it, which we've had a bunch of my patients that are already scheduled, not at my office, but at nursing homes and at where they work, they're at high risk. And if they get it, they could die. So the vaccine clearly for them is a benefit. The question that, will be debated back and forth over the next several months or year is, if you're low risk, should you get the vaccine? Should we vaccinate children with a messenger RNA vaccine? I mean, to me, no. I mean, why would you take something you have no idea what it's going to do over the next 10 years and give it to low risk kids? We're going to have other vaccines that are very boring COVID vaccines by the summer, where they're the old style, like whooping cough, hepatitis B, HPV. Those are very, very standard vaccines with noted histories with that technology. I think for low risk people, that's what they should take. I think the high risk people, the reason we want them to be vaccinated even with this experimental vaccine is, one, it looks highly effective. Two, if they get it, they could get really sick and die. So they're in a different subgroup. And the third thing is, if they're healthcare providers, then there won't be anybody left to take care of us if we get sick. So that's kind of the other part. And then the final part is, if you're at high risk for getting sick and you get sick, you're going to take up a hospital bed. If you end up getting ill, and if we have a deluge of people who are requiring hospital beds and we don't have any, that's a particularly dangerous situation. I mean, if we knew that the next 100 million people in the United States getting COVID were between 2 and 20, we would not have to, it wouldn't be as important because they're not going to get hospitalized. Whereas, unfortunately, the next 100 million people who get COVID in the United States, a huge number of them are going to be over 40, and some of them are going to get really, really sick, unlike kids. So it's going to overwhelm the health system. So that's why giving the group that's higher risk the vaccine now is super important. Does that make sense, Kim? I'm trying to make it sensible.
I think so. Yeah.
It's just, right now, if you're high risk, where do we put you if you get sick? And so if we have 10 high risk people get sick, 2 of them are going to get hospitalized. We would, if we have hospital beds, but since we don't, it would be 1, and then the other one who needs to get hospitalized will miss their opportunity to get early treatment, and then they'll get sicker, and so it's a disaster. So that's the problem. We can't let people who are higher risk get sick.
Okay, so you're ready for not vaccine questions?
Not vaccine questions.
Okay. Can you take Plaquenil and ivermectin at the same time?
So ivermectin is dog dewormer, and I talked about dog dewormer in March a couple times. I posted some original papers on this, and it was pretty funny because there's lots of people who were highly critical of that, and sent me all kinds of nasty stuff that I was like a mad scientist or an idiot or something. Well, lo and behold, jump forward to last week or a week and a half ago, and the International Society of Intensive Disease Specialists have looked at all the data, and they actually refer to it now as a miracle drug for COVID. It's a 99% reduction. That's essentially if you started outpatient for hospitalization. It approaches 100% reduction if you use it prophylactically, and then in the hospital has phenomenal effects too. So ivermectin is extraordinarily well tolerated for people. You obviously would start it earlier than later with if you got COVID. I would still combine it with Plaquenil. That's how I've done it when I've used it on our patients so far. But again, you'll have to talk to your provider about the dosing and all that, because it's just, again, it's just a huge problem because the NIH just will not respond to emergency use authorization applications or anything that isn't big pharma. And so this is the group who's promoting this, who told the FDA, and these are like the smartest critical care physicians in the United States and the world. They're the ones who told the FDA, you're wrong, steroids are the key thing, and it's really the only thing that truly works early in COVID, bar none. It's the only thing that truly works. They were the ones who told the FDA, you're totally wrong. The NIH, the FDA, the CDC, and they finally made them believe it because the data was so incontrovertible. And so that's the biggest savior we've had for COVID. Remdesivir has been shown to be useless, which is what I said again, multiple times. No one even uses it practically anymore. It was all a big scam by Gilead and by the CDC or the NIH people who authorized it, sorry. And because they were all paid by them, or most of them. So now that's not being used. The convalescent plasma is kind of a hit or miss thing. The new antibody that they're giving, it takes 23 people to get it for one to get a benefit. So yes, it works 1 out of 23 times, but it's about a 3-hour infusion. And so it's about 63 hours, I guess, of labor intensity to prevent one person from getting sicker, but then you're wasting all that energy on these other people. And so again, it can work, it's just not working as well as everybody was hoping. So again, the group that has said ivermectin is the group that came up with dexamethasone. There's tons of data. I'll put the white paper, a summary paper, and then I'll put the Dr. Corey's stuff on from his testimony at Congress. I've kind of waited because I wanted it to get more of a life of its own, because I already been criticized so much about it in the past that I just decided to let other people decide to kind of fight the battle lately, because you can only fight so many battles.
Do you still feel with our numbers going up that kids should be in school?
I still think kids should be in school if they're wearing masks, the teachers are wearing masks, and that the teachers have some level of protection. I do think it's fine. I've always thought it's fine. I don't think kids should be, and when I'm saying kids, I'm saying, first grade and up. I think basically they should wear masks, and definitely middle school and up, they should definitely wear masks, and the teachers should wear masks, and anyone who isn't having the teachers wear masks, any school administrators, how do you live with yourself? I mean, come on. They should be allowed to wear masks. I have teachers who come in all the time who work at schools, and they say, oh, no, I'm not allowed to in our school district. I'm like, oh my God. It just drives me insane. Be nice to the teachers, okay? Why? They're taking care of our kids. Be nice to the nurses, but so no. I think kids can still be in school for now. I don't know what's going to happen in January, though, because if our case numbers go the way they're potentially going to go, it may be hard to restart school, even for schools that have done really well and stayed open the whole time. So we'll just have to see. I do know it's a focus of the Oklahoma State Health Department and the governor's office to get kids in school. So they are very committed to it.
After you have recovered from COVID, should you or can you cut back on zinc, or should you stay on your same regimen?
I think if you've actually gotten COVID and you've recovered, I think going every other day, like I usually want people to, or even every third day, then is fine. We're still in flu season, and so again, more zinc during flu season, same process, protective, and so I would stay on every other day.
Okay, and then one more. Two more. Is Regeneron available here, and what are your thoughts on that?
Regeneron is not available here, but there is a different antibody that is available here, which I just mentioned, but I don't pronounce the name. It begins with a B. It takes about 21 patients to get it to have a significant clinical effect. The other 20 do not have harm. I want to emphasize that that's not an issue. It's just incredibly labor intensive for the hospitals. So imagine 3 hours an infusion. And so you have to be monitored the whole time. It takes nursing staff, and there's limited amounts of dose. So it's not giving us the bang for the buck we'd like. Okay. If it was, if it was 21 for 21, we'd be thrilled. But it's just, again, it's not as good as we were hoping.
You had a lot of people asking for your dosing suggestions for both Plaquenil and ivermectin.
I can give that to my patients, and I'll put the white paper on what they discuss in the journal article. I can't give recommendations on dosing for meds. You need to get that from your own provider. that's why you have a provider. So they have to tell you that, but that's how we would approach that. But I've put papers out on Plaquenil a ton of times. Go back and find them. They're in the protocols, in those, they give you the dosing regimen. But that's how I would always ask you to find them is, I mean, if you're one of my patients, I'm going to tell you exactly how to do it, but you have to be sick to get it or be exposed. So we don't just give all we can't do that.
Legally can't. That's it for me.
Okay, so be optimistic. We're going to get through this. I think it's all over around April 15th. Bill Gates said it was a whole nother year and a half away. I totally disagree with that. I think we're going to be really in good shape by mid-April as long as the vaccines come out as planned. There's no snafus, and we actually get the 100 million people in the United States who are at higher risk for disaster with COVID vaccinated. I think we'll be in really good shape by April, but we need to get somewhere around 75 to 100 million of the high-risk people vaccinated as fast as we can. So that's the assumption that we're going to get it done. Thank you. Good night.